Hi, Adam. Hello.
Hi, how are you?
I'm fine, thanks, Adam. You okay?
Yeah, good, thanks.
Yeah, the Yitka is here and TUGS has joined. That means Jack has
Hi,
joined.
Kamal. Hi, Adam.
Hi.
Are you okay, Yitka?
I'm good. How are you?
If I'm a little bit sweaty, that's because I went out for a run just now. So I'm good now. Yes.
Good, good. Oh, I'm glad.
Yeah, you're okay.
Yep, all good.
Wonderful. Good, good, good. Don't see Jack yet, but I think he's just turned this video off, maybe. Apparently, the TUGS Asia meeting yesterday had something like 680 or some attendees. Calvin just sent me an email.
Excellent.
Yeah,
That's amazing.
So yeah, it's really, yeah, it is amazing, isn't it?
It's almost 3 o'clock over here in Rotterdam, the Netherlands. That means almost 2 p.m. in London. So I would like to start with the second TUGS Scientific Sundays. Hopefully everybody's doing okay on their parts of the world. We had a very successful first session, so let's make the second session even more successful. I would first would like to introduce our panel members and my co-moderator for today. My co-moderator, it's been more of a friend than a moderator. I would like to introduce to you Dr. Icg Graham, who is the head of the Helen McArdle Nursing and Research Institute in Sutherland in the UK. Icg, welcome to this second session.
Thank you very much. It's an honor to be here. And, you know, what a great turnout we've got today.
Yeah, let's make it even better. Our first panel member also became more of a friend than a panel member. Tadea Pintar, a surgeon from the University of Ljubljana in Slovenia. Tadea, welcome. And as our last...
hello, welcome.
Hello. As our last panel member, Dr. Adam Frampton from the UK, also a surgeon. Adam, welcome to this session. First, a few house rules. Of course, everybody needs to be muted during the presentations. Otherwise, I'll mute you myself. Secondly, we've changed a few small things due to our last session. First, we made the presentation length 2 minutes longer. So every presenter has 8 minutes for their presentation, and afterwards we will have approximately 2 minutes of discussion, which makes 1 hour of approximately 5 presentations with a bit of spare room in case discussions are getting quite fierce. And that's all. I'm hoping to have a very nice and second session. Let's go to our first presenter, one of my Dutch colleagues and good friends, Dr. Elijah Sanchez. He is going to present about cardiac rhythm disorders before and after bariatric surgery, a systematic review he did with a group of international colleagues. Elijah, you're up. The floor is yours.
Thank you, Jacques. I will share my screen. Is everybody seeing the screen? Okay. It was very strange to be called doctor because I graduated 2 weeks ago. So thank you, Jacques. You're the first person to call me doctor. Without further ado, I want to present something about the article Effects of Bariatric Surgery on Heart Rhythm Disorders, Systematic Review and Meta-Analysis.
Elijah, you need to make your screen full. You need to tap the schermen omwisselen thingy.
Better?
Yeah, that one's better. Thanks.
Okay. what I said, I want to say something about the article I wrote with some of the colleagues over here. These are authors with affiliations. The authors come from all over the world. Obesity is associated with cardiac structural changes and repolarization abnormalities, such as prolongation of the QTC interval, lengthening of the P wave, and QTC dispersion, as well as rhythm disorders like atrial fibrillation. All the Icg terms I will discuss later on. And the aim of the systematic review was to provide an overview of the literature on the effects of bariatric surgery on obesity-associated EKG abnormalities and cardiac arrhythmias. We conducted a systematic search on effects of obesity and bariatric surgery on EKG abnormalities and associated cardiac arrhythmias. The methodological Newcastle Ottawa scale was used to rate the studies. In later sheet, I will show you what the results were. And the agreement between the reviewers was assessed with Cohen's kappa, and we had a score of 0.75. That meant there was a good agreement between the authors. We searched the useful subjects, PubMed, Embase, Medline, and the Cochrane Library. And the patient population of interest were patients with obesity and heart rhythm disorders with EKG abnormalities or proven rhythm disorders like atrial fibrillation. The inclusion criteria were there was a randomized control trial, a prospective cohort study, a retrospective cohort study, a case control study, or a cross-sectional study. Patients need to have obesity and they need to have a scheduled bariatric surgery. What I already said, they need to have proven EKG abnormalities that could be changed in the P-weave, QRS complex, ST segment, or other related abnormalities. And heart rhythm disorders and atrial fibrillation was the one with the highest incidence. And the reported outcome measurements of interest were changes in occurrence of heart rhythm disorders, changes EKG abnormalities, blood pressure, and other anthropomorphic variables like BMI or waist circumference. You can see here the Prisma flow chart. We started with 1,400, a bit more than 1,400 studies. After screening, we ended up with 21 studies. 7 studies were excluded with several reasons. And eventually we included 14 studies in this article. And in the meta-analysis, we used 9 studies, 7 for the QTC interval and 2 for the P-wave dispersion. You can see here the Newcastle Ottawa scale scores. The quality of the studies ranges from moderate to good. The highest score attainable was a 9. Several studies, 2 studies at a 9, but the other studies were a bit lower. I think it's important because not all of the colleagues here have the cardiological knowledge. I also didn't know it before the study. The P-wave is the sum of all the electrical activity from both atria. The P-wave dispersion is a marker for atrial remodeling and a known predictor for atrial fibrillation. And it's defined as a difference between the widest and the narrowest P-wave on a 12-lead EKG. The QT interval is measured from the first deflection of the QRS complex to the end of the T wave at the isoelectric line. And we mostly use the QTC that's corrected for heart rate. And the QTC interval dispersion is defined as the difference between the longest and the shortest QT interval with 12-lead EKG. Now to the results of the study, I think that's the most interesting part. The majority of the study showed a significant decrease of the QT interval and related measures after bariatric surgery. Regarding atrial fibrillation, the results were conflicting. The studies were not sure whether this positive or negative effects. 7 studies were included in the meta-analysis on effects of bariatric surgery on the QTC interval, and a significant decrease in QTC interval was shown of minus 33.6 milliseconds. And also the confidence interval was decreasing. And similar effects were seen regarding the P-wave dispersion with minus 12.9 milliseconds. You can see here figure 2. It was a meta-analysis, and you could see that almost all the studies had a negative confidence interval except the study of Rousseau. But overall, you have a score of minus 33.6 in shortening of the QTC interval. You can see here before and after the malabsorptive bariatric surgery, because we included both malabsorptive as restrictive surgery, and there's not a lot of difference between the restrictive and the malabsorptive studies. You could see here that in the malabsorptive study there was a decrease of -33.9, and in the restrictive studies you can see there's a decrease in -33.4. So there were no significant difference between the two ways. And P-wave dispersion, there were only 2 studies included, but there were also a significant decrease in length of the P-wave dispersion. So the conclusion of this study is that there's a significant weight loss produced by bariatric surgery, and it results in a decrease in the QTC interval and P-wave dispersion. In other words, you have a normalization of the initial pathology, and this result in less cardiac diseases. And the effects on atrial fibrillation are still unclear and conflicting. So there needs to be done further research to understand atrial fibrillation and bariatric surgery better. The study also had some limitation. The quality of the included studies varies from moderate to good. In the ideal world, you only want studies with a higher score. And secondly, what also is important in my eyes, the studies we include not routinely assess metabolic, neurologic, and hormonal factors that might influence all the facts we research, so like the QTC and QT. And most studies we investigate did not take into account the influence of obesity-related comorbidities. There was also a flaw with studies. And finally, we need to take into account that most patients that seek bariatric surgery are female, and it might create a gender difference in obesity-related ventricular repolarization. Why it is not completely clear, but it's something to take into account. And also, some of the studies we include are a bit older, and we know in the field we are working, things are changing fast, so it's important to take it into account. And it was the presentation, 8 minutes. Thank you for your attention.
Sorry. Thank you for a very difficult subject to address as the first one in this second session. Let's go to our panel members. Tadea, any first comments?
Yes, a very nice designed study with important information for the patients waiting for the bariatric surgery. But one of my concerns was would be of great value to do MRI of the heart before bariatric surgery to see even more effects of the bariatric surgery procedures. This was one of, we can find some more details, and of course, I will leave for the next questions then.
So if I understand correctly, whether we should do a cardiac MRI prior to bariatric surgery.
It would be of benefit because we can even exclude some other anomalies of the heart not presentable in the Icg. So
yeah, that's good. That's a good one.
Of course, about cardiac adaptation to morbid obesity is also according to the volume of the heart and the volume of the atria and ventricles. So for greater work.
I completely agree with you. I think it would be beneficial for patients, also for study reasons, to do the MRI beforehand, because then you can see all the morphological changes also. And yeah, it would be nice if it's possible to do that.
Yeah, but it's not standard practice. I think first you need to do that in a well-designed study, because MRI is of course a very costly investigation, and yeah, just to see how the heart's functioning. Yeah, I think you have enough to do a cardiac ultrasound. So Yeah, interesting idea to do a study about. And of course, if there's a clinical indication, yeah, you can always do it, but it's not at this stage not yet recommended for patients with cardiac anomalies prior to surgery.
Oh, at the beginning, I suppose for the research purposes, that would benefit or support even more the results you presented. And some of the questions you answered also already in the limitations of the studies. So very nice work and important message for the patients about improvement of the heart function after bariatric surgery, and some questions remain still unanswered. So what are the precise mechanisms and what to do?
Yeah, that's true. We still have room for one more question. Jitka?
Yeah, can I say thank you so much, Elijah. You know, I know how much time and effort it takes to pull together a systematic review. And I think on behalf of everybody who does research within bariatric surgery, thank you for tackling a topic which is not very well known and really contributing to that evidence base. And just to say, you know, I think just that's fantastic. And the more people within the TUGS community that are prepared to undertake such rigorous systematic reviews, you know, you've really sort of set the bar for us. But have you got plans to publish this? Because this is information that needs to be out there. What's the next steps?
It's already published.
Oh,
I think
excellent.
A couple of months ago, it's published. I wrote it with Shark and a couple of other authors a couple of months ago. So it's already published and you can find them PubMed.
Right. Okay. Brilliant. Thank you.
So it's out there for everybody to read.
Out there.
Okay. In the interest of time, we will continue with the next presenter. And the next presenter is Dr. Jure Solobier. And the talk is about liver function monitoring in bariatric patients, preliminary study results. Jure.
Yeah. Hi, nice to meet you. So as said, I would like to present you the preliminary study results of liver function monitoring in bariatric patients. Why we would monitor that is because of non-alcoholic fatty liver disease that I'm sure you all know intimately. In bariatric patients, it occurs in 90% or more than 90%. And in the advanced stage of non-alcoholic steatohepatitis, it's common up to 40% of patients undergoing bariatric surgery. And it can, of course, progress to fibrosis, cirrhosis, and hepatocellular carcinoma. The treatment is with diet and lifestyle modification. Drugs are currently only in development phases. But in bariatric patients, surgery has had great results in improving NASH in 85% and fibrosis in 34%. But of course, in end-stage disease, liver transplant is the only treatment option. The problem, or one of the problems in NAFLD, is the diagnosis. NAFLD is defined as steatosis in more than 5% of hepatocytes, measured either with histological analysis or advanced imaging methods. And of course, with the absence of other causes of liver damage. To facilitate identification of patients at risk and at secondary and tertiary level to monitor disease progression and response to treatment, non-invasive markers are sought. Currently, these are mostly biomarkers of different aspects of NAFLD, such as apoptosis, inflammation, fibrosis, which are then grouped into scores with different prognostic value. If we could improve in this area, we would be able to reduce the need for liver biopsy, and it would be of great prognostic significance for these patients. One of potential tools is liver function monitoring using Icg pulse dye densitometry. Iodocyanine green is a water-soluble fluorescent dye that we can measure in the bloodstream. It has a very high liver extraction rate. It is extracted unchanged through the liver and excreted into the bile. It has a very short lifetime and very low toxicity. And when we inject it into the bloodstream, we can monitor it using a clip-on sensor such as this. It gives us a curve that shows it under the A, the circulatory phase, and then the liver uptake and elimination. It's already used a lot in ICU patients, in liver transplant and major liver surgery. It is limited mostly by the influence of the heart, because the liver function is in normal conditions very dependent on cardiac output. It is also not precise in biliary obstruction, because it involves the same transport carriers. So if we do logarithmic transformation of this curve that we get, we can achieve two measurements. One is the slope of this curve, which is named plasma disappearance rate, or PDR, and the other is the retained Icg after 15 minutes, which is called R15. Why we believe this would be possible to measure in non-alcoholic fatty liver disease is because the same transporters that are identified in Icg, the transport have been shown to be reduced in non-alcoholic fatty liver disease. And the preliminary study published in 2018 showed a significant correlation of R15 with steatosis, fibrosis, and NAFLD activity score. But there was no follow-up published as of yet. So we designed a similar study with patients undergoing bariatric surgery, where we measure Icg elimination using a Limon sensor before the surgery, and then compare it to a histological sample that we obtained during surgery. The histological analysis is done according to the Kleiner classification, and here you can see the before mentioned NAFLD activity score, which is the sum of scores for steatosis, inflammation, and hepatocyte ballooning. And these are our results to date. We have included 24 patients. Our goal is 75. And we have already shown statistically significant correlation in steatosis, inflammation, and NAFLD activity score, but not so much for ballooning and fibrosis. With these results and the rise of non-alcoholic fatty liver disease, the identification of these patients and proper monitoring is more and more important, especially in bariatric surgery, where we have a tool with which we can improve liver function. And if our study continues in the same direction, we could show that Icg pulse dye densitometry could be an important tool in achieving that. Thank you.
Yes, thank you, Jure, for a very interesting talk. I was especially triggered by all the histological pictures in your presentation. Reminds me of my own pathology internship way back, way too long ago. Any questions from our panel? Perhaps Adam, you have any comments or questions for Jure?
I think this is a great study. You know, I know you've only done to 24 patients, but I think it's a brilliant study that you've done. Icg is being more and more used now in like you say, in liver surgery, we're actually looking at patients pre and post chemotherapy, because as you know, chemotherapy can also induce steatohepatitis. I was just wondering, you said that you think 40% of bariatric patients have abnormal liver function, is that right?
No, I said they've shown that 90% have NAFLD and 40% have NASH.
Fine. So
have NASH, yes, the advanced stage.
So by just doing the bariatric surgery, of course, you hope to improve on that.
Yeah.
Are you suggesting that perhaps you would consider doing bariatric surgery on someone who was not necessarily obese, but just had NAFLD? Is that what you're suggesting, that this may go?
Probably
in that
not.
direction?
Probably not. But in the 35 to 40 BMI zone, this could probably be an indication. You know, because now we have arterial hypertension and diabetes that can tilt towards bariatric surgery. And this could probably be a group of patients that could also benefit in that, but probably bariatric surgery is not appropriate for people who don't have raised BMI.
Okay, fair enough. So are you going to start doing your ICG on all of your patients now?
Yeah, we're doing it on all bariatric patients.
Okay, brilliant. What's your target number? You've got 24.
Yeah, 75 is our target number.
Okay, great. No, I'm very impressed. Actually, it's a nice little study. You should
maybe a good one.
Continue your patient recruitment.
Mm-hmm. And you've had some great comments in the chat just on your presentation as well. So please take a look at that. You should be very proud of yourself.
Thank you.
One final comment before we go on. Maybe if you completed your study, please resubmit it and present your final results over here. That would be very nice. So keep that in mind. It was a nice presentation.
May I have a question, please?
Yeah, sure.
Just to support my colleague, are there any other tricks you are doing in the study? For example, how to present the cardiac function in the liver NAFLD patients? Are there any news also for this field?
We are trying to diminish the effect of cardiac output on liver function monitoring with non-invasive cardiac output monitoring, but yeah, we don't have any results to show yet. But the idea is that if we can diminish the effect of cardiac output, if we can take that into account, that perhaps the ICG measurement would be even more relevant.
What about the adjustment of the results of liver function test? Did you already find some connection, or mostly the patients have a normal liver test?
No, yeah, we've shown some pathologic liver tests in those patients, but we haven't yet analyzed to see if there's a correlation with the level of histological damage to those liver.
I was just thinking, Jure, you're doing the ICG and you're obviously taking a liver biopsy at the time of bariatric surgery, yeah?
Yeah.
It would be really nice to repeat the ICG and get ethical approval to do another liver biopsy, perhaps 6 months post-bariatric surgery, to see the effects, not only on the ICG, but also on the liver, steatosis, ballooning, all of this histological markers. If you could get ethical approval to do another liver biopsy follow-up with another ICG, that would really be interesting, I think. What does the rest of the audience and people think?
it is easier to get an ethical approval for another ICG regarding to liver biopsy that it is very difficult to obtain. Even in the last time, we had some complications of the liver biopsy from gastroenterology department. This also importantly reduced the possibility to get the ethical approval for the next biopsy, but it would be of great help, of course.
I think there's something on the chat that I just saw come up.
We will ask
says
for...
that there are some data on paired liver biopsies in the literature showing improvement even in fibrosis. Yeah. I think if Jure could correlate even in just a small subset of patients, some small cohort of patients, the ICG and liver biopsy 6 months post bariatric surgery, for example, that would really be nice. I think it'll all be up to your ethical board, won't it?
Yeah.
But do you suppose 6 months is the proper period, or we would rather wait for 1 year after a bariatric surgery? Because according to the results, nearly 80% of the patients have more than 80% excessive weight loss at 1 year after surgery. So
yeah, sorry, I apologize. I'm an HPB surgeon. I'm not a bariatric surgeon. So yeah, whenever the maximal weight loss.
Yeah.
Sorry about that. So 1 year then. But what I'm saying is there's a follow-up biopsy with an ICG. Yeah.
I like the ideas that are keep flowing around, but we need to keep track on our time and the rest of our presenters. Jure, again, thank you very much. If you want to spar on ideas or something else, please reach out to us.
Thank you very much.
It would be lovely to help you. Let's continue to our next
me too,
presenter.
Jure. Yeah.
Let's continue to our next presenter. Our next talk is about periodontal health of patients indicated for bariatric surgery, presented by Diana Kolak. Diana?
Hello, greetings everybody. It's an honor to be here. Today, I'll talk to you about periodontal health of patients indicated for bariatric surgery. And first of all, I'll tell you something about periodontitis and its connection to obesity and bariatric surgery, what is our main study questions, and the results we got and how we interpreted them. So what is periodontitis? Well, this is an inflammatory chronic disease of two supporting tissues. It is caused by dysbiosis of dental plaque bacteria, and it's the leading cause of tooth loss. And what is connection between periodontitis and obesity? Well, patients with obesity are at higher risk for periodontitis. Periodontitis has a negative effect on their oral health, as expected, but periodontitis is also a risk factor for many systematic diseases, also for obesity. And how can periodontitis negatively affect systematic diseases? Well, this answer is a little bit more complicated, but simply put, inflammatory mediators and bacteria with the byproducts go into circulation and reach distant tissues. And what about bariatric surgery? Does it affect periodontal health in any way? Where unexpectedly, even though general health improves, after bariatric surgery, periodontal health may worsen. And all of these reasons are pointing out to that oral health is important for bariatric patients, but so far any kind of dental examination is not recommended to bariatric patients. And with this study, we wish to raise awareness of dental health in these patients. So our first study question is, do patients aimed for bariatric surgery have a high prevalence of periodontitis? And our second question is periodontitis associated with certain obesity parameter or systematic disease in these patients? And to answer these questions, we performed cross-sectional study where 64 patients indicated for bariatric surgery underwent periodontal examination, and other data like their general health and other diseases present, were taken from the medical records, and behavior patterns by interview. So what have we found so far? To answer the first question, do bariatric patients have a high prevalence of periodontitis? The question is yes, and it's higher than expected in general population. But here it's very important to point out the low prevalence of periodontally healthy patients in this group. And how advanced is periodontitis in these patients? Well, when looking at stages of periodontal disease, there are more higher stages of the disease with faster rate of progression and with a generalized extent of teeth involvement. And when looking at the second question, is periodontitis associated with certain obesity parameter or systematic disease in these patients? We compared periodontitis group versus non-periodontitis group in obesity parameters, disease diagnosis, and behavior habits. And this is the list of parameters that do not differ between these two groups, as is BMI, gender, or diabetes mellitus. But periodontitis patients do show a higher prevalence of hypertension. They're older in age. They have more heavy smokers in their group, and they have higher stages of Edmondson obesity staging system. And we explored the association between periodontitis and hypertension with logistic regression model, where we found that periodontitis is the only variable that is associated with hypertension. But I should also point out that age has borderline significance as well. And the second association we explored is between periodontitis and Edmondson obesity staging system, but here only stage was associated with this staging system and not periodontitis. So what can we conclude in the end is that, yes, patients indicated for bariatric surgery do have a high prevalence of periodontitis, and there is a very low proportion of periodontally healthy patients in this group, and that in this patient with obesity, periodontitis was positively associated with hypertension, regardless of other confounding factors. And our clinical recommendation would be that patients indicated for bariatric surgery should be screened for periodontitis before the surgery, as it may affect not just their oral health, but their general health as well. And thank you all for your attention.
Yes, thank you very much, Diana. I was just wondering what is known about the mechanism of worsening of periodontitis after bariatric surgery.
There are a few mechanisms that might be at play here. First of all, is the change in their diet straight after the surgery. First, because after the surgery, they are on liquid diet, and then they go to soft food, and then after a few months or few weeks actually on solid food. So that change, and they have around 5 meals a day. So all of this increases the risk for periodontal disease, also for caries. That will be one of the mechanisms. Others, the research points out to malnutrition happening after the surgery, in the lowering of calcium, vitamin D that affect bone around the tooth, alveolar bone.
Yeah, apologies. I needed to close my door because there's some people already think that the Netherlands already won European Championship. Oh. Yeah, just one other question. Did you check something about the diet of the patients that were included in this study in terms of sugar consumption, soda consumption, etc.?
Mm-hmm. Thank you. We didn't collect exactly the data, but usually they say that they do prefer more sugary food. Some of them say, oh no, I eat everything, or they're on some kind of a diet, restrictive diet, like with high proteins. So, but we wanted to keep away from collecting too much data on the on their diet, as it has a high level of bias. But
I have a, can I?
Yeah, sure.
Yes, but I need to support my colleague, because I send the patients to the Department of Periodontology. So in the first meeting, we suggest the patients to change the diet, to go from average 2 to 3 meals daily to 5 to 6, and to take more protein and to reduce carbs. So when they are first seen in the Department of Periodontology, they have on a way changed diet concerning the diet that they have when they first came to the surgical department. So some lifestyle adaptations are on, but I have one question. Did you check how many of the patients have metabolic syndrome already present? And my next question would be, are you thinking also to check the microbiome in these patients, because of the close to the teeth, there are certain changes, and following the literature results, some correlations might be found according to the periodontal microbiome and, for example, liver disease?
Thank you for the question. First question was regarding metabolic syndrome. Yes, I checked the presence of metabolic syndrome. There was no difference between periodontitis and non-periodontitis group in the presence of metabolic syndrome. And yes, I think it would be great to include microbiome of the oral cavity, as some studies already showed that after bariatric surgery, the numbers of periodontopathogenic bacteria increase. So it would be very interesting to see in these patients what will happen. And
I think it's very important, actually. This the microbiome has become so trendy now to investigate. There was some. I know it's not. This is not cancer, but there were some esophageal cancer papers I've seen where they looked at periodontal bacteria, and they correlated between this and post-operative chest infection. In your patients, those with periodontitis, did they have any more post-operative bariatric post-operative complications, chest infection, wound problems, etc.?
Honestly, I don't think so. But we will, because the patients that we checked before the surgery are now going on to bariatric surgery, and we will check if there are any complications. But so far in literature, it didn't show, but there are not many studies on periodontal health in these patients. So thank you for idea. I will check.
Yeah, and then like Tadja just said, you know, I guess these patients need a comprehensive sort of dental examination and maybe treatment like chlorhexidine mouthwash or something like that, you know, preoperatively and postoperatively.
It's quite interesting, you know, being a bariatric surgeon myself for the past 13 years. I mean, I just commented in the messages that I haven't really seen that or heard that in any bariatric program. But in retrospect, you know, I haven't done much, probably 2,500 cases so far. But in retrospect, I didn't have a patient who really complained of any oral problems post-op. And I'm talking about the follow-up of like a long follow-up, more than 8 years of about 30-35%, and another, I mean, I don't recall that in the acute phase or in the long run a patient complained of any oral problem. I'm not saying that this is not important. I mean, but I believe we need to dig into it more and probably get numbers and percentages. But as an observation, I haven't seen it. I mean, I don't recall one patient who complained of oral problems.
Yeah,
the other thing I was thinking is that, you know, the microbiome is becoming so important now in all benign disease, cancer. I'm just wondering that perhaps if you investigate the microbiome, those with periodontal disease or periodontitis.
Yes, periodontal disease.
Perhaps those with periodontitis, they may have less weight loss afterwards or more weight loss after bariatric surgery because the microbiome in the oropharyngeal area is going to influence the gut microbiome, and that may influence weight loss, etc., etc. It'd be really interesting to see the follow-up.
It is interesting, but you'll have one problem here. I mean, to know the correlation, then you have to do oral examination for every patient before and with the follow-up.
Yeah.
I don't know of any insurance program that covers that.
Absolutely, yeah.
And that would be a significant problem in places where it's mostly insurance-based practice like mine. It's like 95% insurance-based. And where you find really, you literally have fights to approve endoscopies for patients who deserve it by all programs. So it's really worth it, but the financial part of it will probably be a hurdle.
Yeah, but I think Safwan, it's a unique. First of all, Diana, this is a unique subject.
Yes, it is.
I haven't heard it in the last decade,
yeah.
And it's definitely worth studying. And but how to design a bigger follow-up study? Yeah, that's also what TUGS is all about. Reach out to us. We'll help you design something.
Yeah, for sure. I think it would be nice to take swabs, do some 16S DNA sequencing for the microbiota, and then have a nice follow-up. You could even do fecal microbiome as well to see the correlation between, those with periodontitis and not, and weight loss not, those.
Yeah, seems like.
Can I interrupt a little bit? But the key point is that nearly all of the patients have one of the eating disorders. So it is related to, of course, to the oral health. But as Diana didn't mention, she performed intervention 1 month before surgery, and then the next check is 3 months after surgery. And of course, we have also to join the other possible things that might be in play in periodontal disease. For example, supplementation, the level of calcium, and of course the previous grade of dental status. So there are a lot of points here, but for the remaining, it is highly important. Even if patients do not complain about oral health, it is mostly presented in this cohort of patients for many known and unknown reasons.
I love the lively discussions, but we still have 2 presentations left. So I would like to continue with the next speaker, who is actually going to present two talks. I would like to introduce Eli Kakiasvili. His first presentation: many ways to skin gastric cancer, robotic versus laparoscopic versus open gastrectomy. Eli, the floor is yours.
It's actually, the screen is yours. There are no floors anymore.
Yeah.
But we're still hanging on to it.
So hello, everybody. Can you hear me?
Yeah.
Thank you very much for having me on today's scientific meeting. It's a really great pleasure to be here and share with you our experience. As you can see, the topic of my presentation is many ways to skin gastric cancer, robotic versus laparoscopic versus open gastrectomy. I'm sure you all know that overall incidence of gastric cancer has rapidly declined over the past 50 years, at least in Western population, but unfortunately, gastric cancer still remains one of the leading causes of death from cancer worldwide. The introduction of screening program for gastric cancer has enabled to increase the 5-year survival rate to almost 60% in Japan and in many other Asian countries, but unfortunately, remainder of the world still has very poor 5-year survival rate, less than 25% for stage 2 and beyond disease. You all know that a lot of progress has been made during the past few decades in the management of gastric cancer. Lymph node staging has been refined, perioperative mortality has fallen, neoadjuvant and adjuvant therapy has emerged, but you all agree that still complete surgical resection is currently the only modality that may offer a cure for patients suffering from gastric cancer. Interest of minimally invasive surgery in the treatment of gastric adenocarcinoma has rapidly increased following the first report of laparoscopic gastrectomy in 1994 from Japan, and today the use of laparoscopic assist surgery in the treatment of gastric cancer has become widely accepted in the field of minimally invasive surgery due to all advantage of laparoscopic technology. I'm sure all of you are familiar, such as less invasive, less pain, speedier patient recovery, shorter hospital stays, better cosmetic results. But we all know that conventional laparoscopy still has limitations such as two-dimensional visualization, restrict range of motion, amplified physiologic tremor, the uncomfortable position forced upon the surgeons. Da Vinci surgical system was invented in order to overcome limitation of conventional laparoscopy and offers greater surgical precision and ergonomic comfort, increased range of motion, improves dexterity, enhanced visualization, and improves our access during surgery. But the really question is whether or not robotic surgery in gastric cancer patients is comparable to laparoscopic and open surgery in terms of oncological adequacy and safety. That's what we tried to figure out according on our experience. So aim of our study was to evaluate the safety and efficacy of Da Vinci robotic gastrectomy as compared to laparoscopic and open gastrectomy for gastric cancer. For this, we retrospectively analyzed electronic chart of patients who underwent elective surgery for gastric cancer at Rambam Healthcare Campus and Galilee Medical Center between 2013 and in 2018. All patients above 18 years old who underwent surgery for gastric adenocarcinoma in the intent for cure were included in study. All patients who underwent surgery for palliation complication of gastric cancer or were found to be inoperable during the index operation were excluded from study. Patients' data was collected based on basic demographic characteristics, BMI of patient, operating room time, number of retrieved lymph nodes during surgery, length of hospitalization, intra and postoperative complication. Total number of patients included in study was 104 patients, 59 total gastrectomy and 49 subtotal gastrectomy. In total gastrectomy group, as you can see, 14 patients were operated by robotic technology, 17 underwent laparoscopic total gastrectomy, and 28 patients open surgery. In subtotal gastrectomy group, 26 patients were operated by robotic technology for laparoscopy, and 15 underwent open partial gastrectomy. And when we compared three different groups, in total gastrectomy group, we did not find any significant difference in terms of age of patient. There was no significant difference in terms of BMI of patients. Postoperative discharge of patients underwent robotic gastrectomy was much faster than in laparoscopy and open surgery, median 4.5 days versus 7 versus 9 days. And as you can see, the difference between groups was statistically significant. Operating room time, obvious, was much higher in robotic technology than in open surgery, but we did not find any significant difference between robotic and laparoscopic group. And according on our experience, we deeply believe that after overcome of learning cure, you can decrease significantly docking time during surgery and of course decrease operating room time. In terms of oncological results, we achieved adequate lymphadenectomy in 3 groups. And as you can see, there was no significant difference between group. And we did not see also any significant difference between group in terms of postoperative complication. In partial gastrectomy group, there was no difference in terms of age. Our patients were pretty homogenic from BMI point of view. Postoperative discharge of patients underwent robotic subtotal gastrectomy was shorter than laparoscopic and open surgery, median 4 versus 5.5 versus 10 day. Operating room time, again, in robotic technology was higher than in open surgery, but we did not see significant difference between laparoscopic and robotic technology. From oncological point of view, we achieved adequate lymphadenectomy in laparoscopic and robotic group, but in open surgery, our results were a little bit disappointed, 9.5 lymph nodes, which is not acceptable in oncologic surgery. And we have explanation regarding this issue. If you want, I can discuss it at the end of my presentation. So in summary, as you can see, according on our experience, robotic assist gastrectomy for gastric adenocarcinoma is a safe procedure and are associated with oncologically adequate lymphadenectomy, faster patient recovery, and longer operating room time. I think the greatest advantage of robotic approach may be the potential for many surgeons carry out technically demanding operation more easily in a less invasive technique. The learning curve and reproducibility of robotic gastrectomy seems to be much shorter and more feasible than with conventional laparoscopy. Thus, we believe that robotic has the potential to contribute a standardization and major diffusion of minimally invasive surgery for the treatment of gastric cancer. For sure, more studies are necessary in order to assess adequately the indication and oncological effectiveness of robotic treatment of gastric carcinoma, but I think even today we cannot ignore benefit of this technology. I think that we can say pretty confidently today that robotic assist gastrectomy is a valid alternative to conventional open or laparoscopic resection for the treatment of early stage gastric carcinoma. And I deeply believe that with a steep learning curve, reasonable oncological results and complication, Da Vinci robotic gastrectomy can become the procedure of choice for any operable stage gastric cancer patient. Thank you very much.
Thank you, Eli. Very nice presentation. Any questions from our panelists? Perhaps Tadeya?
Yes, I have one question. Can you give us some results according to the preoperative staging of the operated patients, comparing robotic and laparoscopic groups? And the second question would be, did any of these patients have a preoperative radio or chemotherapy or neoadjuvant complete?
Not radio, chemotherapy.
Sometimes we have been taught that these patients are easier to operate, to being operated openly, but as the new possibilities are on, even with intraoperative Icg for lymph nodes and so on, or many others, what would you suggest?
Okay, thank you very much for your questions. Look, when you are judging regarding operative approach for gastric cancer, what means by the book indication for robotic gastrectomy, what we have today, it's a early gastric cancer. So those guidelines are coming from Asian country because they have very high incidence of gastric cancer. In Western population and in my country, we don't have early gastric cancer. Most of the patients in Israel, they have locally advanced gastric cancer. And your question regarding neoadjuvant chemotherapy, most of them, they are getting neoadjuvant therapy. So If you are asking what is the selection criteria for when we are choosing approach, we don't have selection criteria. I mean, we have only locally advanced gastric cancer, and we are operating by minimal invasive technique. Now, regarding the Icg probes during surgery, we don't use usually Icg navigation and Icg technology in order to figure out and in order to judge regarding involved lymph node during surgery. We don't use it. We have very standardized approach what we are doing in terms of lymph node dissection. In my hospital and in my department, we are following the policy. We are doing modified D2 lymph node dissection. That means to clean lymphatic lymph nodes around common hepatic artery, left gastric artery, splenic artery, and sometimes also celiac trunk.
But I was just wondering about if these patients are giving preoperative chemotherapy. Do you routinely perform preoperative CT scan to establish the reduction of the disease or not?
I mean, we have guidelines, also world guidelines, and in my institution also, all patients before surgery, they are getting CT scan of abdomen and chest wall. Also, we are doing diagnostic laparoscopy if we have to give a preoperative neoadjuvant therapy and oncological markers, of course. Yeah.
No, I was just wondering if there is a huge reduction of the disease after chemotherapy. Will you change your approach or not?
No, usually no. Yeah.
Concerning the laparoscopic or robotic, not the lymphadenectomy.
Look, I mean, we start laparoscopic technology for gastric cancer sites also 15 years. Then when we got robot, we switch our practice to robotic technology. So only limitation for robotic technology is the price of surgery because it's a very high price. So if patients, they are getting insurance for robotic cases, we are operating by robotic technology. If not, we have laparoscopy. So when we have to do multivisceral resections, in gastric cancers, or we are using open technology.
I think we need to go on to the final presentation, Eli, which is also from your hand. We'll try to answer more questions after the last presentation. For the final presentation, you're going to talk about the role of robotic surgery in the management of benign hepatobiliary diseases.
My second topic is robotic assist surgery for benign hepatobiliary disease. As you all know, in the last 3 decades, laparoscopic surgery has gained a worldwide interest in many specialties. However, several technical drawbacks and steep learning curve of this technology has limited diffusion in complex general surgery procedure. And I mentioned, and I would like to underline once again, the limitation of conventional laparoscopy, such as 2-dimensional visualization, restrict range of motion, amplified physiologic tremors, the uncomfortable position forced upon the surgeon. As I mentioned previously, robotic assist surgery was invented in the late 90s in order to overcome technical limitation of conventional laparoscopy and offers greater surgical precision and ergonomic comfort, increased range of motion, improves dexterity, enhanced visualization, improves access during surgery. But the use of robotic assistants in the field of hepatobiliary surgery remains relatively unexplored, at least in my country. So we tried, according on our very initial experience, to figure out what is the safety and efficacy of robotic assist surgery in patients with benign hepatobiliary disease. Again, we retrospectively analyzed our data. All patients above 18 years old who underwent surgery for benign hepatobiliary disease by robotic approach were included in study. This table actually summarizes our data. Finally, we did 36 cases, 6 cases of anatomical liver resection, and most of the surgery was done for symptomatic giant hemangiomas. We did 9 cases of giant liver cysts, I mean simple cysts and hydathic cysts also. We did 5 cases of type 1 choledochal cyst, excision and Roux-en-Y anastomosis, 4 cases of excision of benign CBD structures, and all structures were caused by iatrogenic injury during previous laparoscopic cholecystectomy. We did 6 cases of CBD exploration for refractory intra common bile duct stones, and at the very early stage of our experience, we did also 6 cases of robotic cholecystectomy in order to get familiar with robotic technology. Now let me show a couple of short videos. First case I would like to show you is 29 years old patient. She was diagnosed giant hemangioma in left lateral segment of the liver. We referred this patient to operating room. We start operation by releasing of falciform ligament as in laparoscopic and open surgery. Then we mobilize left lateral segment of the liver. This part of operation can be done very successfully by monopolar energy. And after mobilization of left lateral segment, we start to transect liver parenchyma. And for liver parenchyma transection, usually we are using a combination of harmonic scalpel and bipolar energy. At the advanced stage of resection, we are using also vascular stepless, and I believe that proper using of vascular stepless during linear transection of hepatic parenchyma can decrease intraoperative blood loss and also rate of postoperative bile leak. After transection of liver parenchyma, we did hemostasis by bipolar energy and also used hemostatic glue. At the end of operation, we put a Jackson frat for postoperative draining. Next case I would like to show you is 30 years old female patient. She's got a symptomatic type 1 choledochal cyst, which was diagnosed on MRI of the abdomen. We decided to operate this patient. We start operation by cholecystectomy. As you can see, we just clipped and divided cystic artery and cystic duct, and then we start to mobilize choledochal cyst from surrounding structures, which is proper hepatic artery and portal vein. Most of the dissection, again, can be done by monopolar energy. As you can see, the choledochal cyst firstly was dissected distally, and we transected choledochus. You can see we just clipped it and transect. And then we continuous mobilize choledochal cyst cephalad, and finally choledochal cyst was mobilized and transected. Of course, frozen section intraoperatively was done in order to rule out evidence of malignancy, and there was not malignancy. And then we start to perform end-to-side hepaticojejunostomy. And I think this is a stage of operation where we have to appreciate the advantage of robotic technology, because reticulated instruments and very stable view of operating field can make this part of operation very enjoyable comparing to conventional laparoscopy. As you can see, firstly, we built posterior wall of anastomosis, and then we start to build anterior wall of anastomosis. Of course, this type of anastomosis can be done by continuous stitch, but in this particular case, we decided to use single stitch, Vicarious 3O. Finally, anastomosis was complete. And at the end of operation, we used again Jackson Pratt for postoperative draining. This particular case takes 225 minutes. On day 5 after operation, patient was discharged home, and there was no evidence for malignancy. Next case is exploration of CBD due to large CBD stone, 63 years patient. She had previous cholecystectomy 30 years ago, and then she's got refractory CBD stones and recurrent attacks of ascending cholangitis. We decided to operate this patient. After adhesiolysis, we finally identify common bile duct, which was dilated, and we start to dissect common bile duct from surrounding structures, which is proper hepatic artery and portal vein. For dissection, we use combination of sharp and blind dissection. Finally, common bile duct was dissected completely. And due to large stones inside of common bile duct, we decided to transect completely common bile duct. And then we evacuate the stones from common bile duct. You will see very soon. You can see the large stone insides of common bile duct, and distal part of choledochus was closed by single stitch, and then we made incision in first part of duodenum and start to build end-to-side choledocho duodenostomy. And for anastomosis, we use same technique, single stitch. I want to show you final view of our anastomosis and move to next case. This is a final view. Operating room time was 210 minutes. Day 4 after operation, patient was discharged home. So next case was very tough case, robotic excision of iatrogenic intrahepatic duct stricture and Roux-en-Y hepatic oxygenostomy. 28 years old female patient. She was operated in other hospital. During operation, there was iatrogenic injury of middle common bile duct, and then she's got a refractory structure. We tried to delete it a couple of times in ERCP, but we did not success. You can see on ERCP, ERCP and MRCP, there is a cutoff, almost cutoff of middle common bile duct. So we decided to operate this patient. It was a very tough case because a lot of adhesions and very significant inflammatory reaction and around hepatoduodenal ligament. But slowly we start to dissect common bile duct, and finally common bile duct was mobilized. We did resection of structure, and we performed hepatic oxygenostomy end-to-side, and we used same technique. So I think we can move to another case. So this case took around 320 minutes. Day 5 after operation, patient was discharged home. Final pathology shows CBD with severe inflammation. And my last case I want to show you, robotic excision of hydathic cyst, 54 years old female patient. She's got huge hydathic cyst in the left lateral segment of the liver. We decided to operate this patient. We found adhesions between left lateral segment and small curvature of the stomach. We divided those adhesions. Then we covered operating field with wet pads with hypertonic saline in order to avoid dissemination of hydathic echinococcus intra-abdominally. And then we inject inside of cyst hypertonic saline. And after waiting of 20 minutes, we start to open hydathic cyst and evacuate echinococcus by suction. But then we got impressions that there is another room posteriorly, so we decided to mobilize left lateral segment of the liver. And finally, we decided to transect the liver parenchyma together with a capsula of echinococcal cyst. That's what we done. For transection, we used a harmonic scalpel. Finally, we complete the transection and we cleaned the cyst inside from dirty materials, and finally we put Jackson Pratt and complete this procedure. This particular case took 150 minutes. Day 4 after operation, patient was discharged home. Final pathology showed echinococcal cyst. So general morbidity in our series was 3.8, which is pretty acceptable. There was no mortality. And here is our conclusion according on our very initial experience. We think that robotic assist approach is feasible and can be safely performed in patients with different hepatobiliary pathologies. And I think further evaluation with clinical trials is required to validate its real benefit. Thank you very much.
Thank you, Eli. This was really impressive. I was really enjoying the presentation. We're a bit over time, but that's not a problem. Perhaps some comments from our panel. Perhaps Adam, do you have anything to say about these two great presentations?
No, I think it's very impressive, Eli. How long have you been doing the robotic program? I missed that bit.
I did not get question. How long we are doing?
How long have you been doing the robotic program?
We start robotic program in Rambam Healthcare Campus in 2013. I mean, general surgeons who start this program, urologists in 2007, and then join gynecologists in 2009, and then we start. In 2016, I moved from Rambam Medical Center to Galilee Medical Center, and our CEO of hospital approved that we are getting robot next month here, the Icg system, but I'm continues to operate in private practice robot. We have 10 systems in Israel, 3 systems in private hospital, and 7 systems in government hospitals.
That's very impressive. Are you just doing the malignant esophagogastric, or are you doing malignant pancreas and liver as well?
We have experience in robotic Whipple operation, but we so far did 11 cases, but most of the Whipple procedure, there are robotic laparoscopic assist, because the resection we are doing laparoscopically, and then for reconstruction we are using robotic system. Because I think to do resection laparoscopically, it's much easier, because when you are moving a lot of during surgery in abdomen, robot, it's not so convenient. And the lack of SI system, we did not have robotic ligature. We have only monopolar and bipolar energy. So most of the resection we are doing laparoscopically, but when we are doing reconstruction, we are using robotic system. Actually, this is the benefit of robotic system to do reconstruction surgery.
Okay, well, you've got a great experience. There's a question on the chat. It says, Martaz Eweda, do you not prefer side-to-side choledochoduodenostomy better than end-to-side?
Say again?
Do you not prefer to do a side-to-side choledochoduodenostomy rather than an end-to-side? That's the question on the chat.
I think you can do side-to-side, you can do end-to-side. Both of them, they are okay. I think, yeah, you can do side-to-side anastomosis. That's pretty acceptable. It's okay.
I guess the benefit of that anastomosis is that you still have access from the native duodenum, isn't it? Not access for the common bile duct from the native duodenum. The other question is, you have done end-to-side regarding the distal CBD stump. The distal, how do you close your distal CBD stump? That's the question on the chat.
Distal CBD stump, you can close by single stitch and also continuous. You can put clip. All techniques, they are acceptable.
Cool.
One more question, please.
Yeah, sure, go ahead.
I'm Dr. Ioannis from Saudi Arabia. Congratulations, first of all. Very, very good job. Excellent. My question is, we saw one video, the exploration of common bile duct for stones. Why you didn't do exploration and only closure of the common bile duct?
What is the question again? I could not hear you, you know. I mean,
yes. I saw a video with exploration of a common bile duct because of stones. Finally, you make jejunal anastomosis. Why you didn't make exploration and closure of the common bile duct or anastomosis again?
Yeah, this is options. That's what we are doing usually. But this patient had huge stones, so we are afraid that we will have problem during evacuation of the stones. I mean, what we decided to transect common bile duct and then to do end-to-side choledochondrodynostomy, which is physiologic anastomosis. I mean, it's a physiologic anastomosis. But you can do incision of common bile duct and try to figure out. But when patient has huge stones, it's a little bit traumatic to evacuate stone from incision above common bile duct. But you can try, that's okay. This is the option, yeah.
Thank you.
I think we need to, we can close this second TUGS Scientific Sundays. I would like to thank all the presenters today for their great presentations, the great discussions we had. What I would finally want to say is that we have a few posters on our website, tugsglobal.com. This section is going to expand in the next few months. There's some great posters on cardiac remodeling and endothelial function in bariatric surgery, and two about the effects of COVID on other diseases and also the abdominal symptomatology that can be present in COVID. Finally, every presenter from both poster and oral presentation will receive a certificate, which will be emailed somewhere in the next few days to your email address. And finally, I would like to thank our panel members and my co-moderator. Any last words from our moderators? Perhaps Tadeya, any last words to say before we close the session?
Just to say thank you so much.
There were extremely nice presentations, and also the presentation of extremely high experience in the field. So, and extremely nice teaching message for all the participants, I suppose. Thank you very much.
Yeah.
Adam, any last words?
No, I think this was fantastic. I reiterate that you know, high quality presentations, great discussion. Really enjoyed it.
Awesome. Jitka, any last words?
Yeah, just to say again, just to echo what my two colleagues have said, fantastic presentations. I think the quality and caliber and the rigor of these presentations is really to be commended. And just thank you for all the work that you've put in and the support everybody is giving TUGS. I'm just really proud to be part of it, and I hope you all are too. And thanks, Jack, for pulling these together.
Yeah, you're welcome. I'm enjoying this also. I'm already looking forward to our next TUGS Scientific Sundays, which will take place in July, the last Sunday, of course. And we'll send out emails. So everybody, if you want to send in an abstract, be my guest. We have more than enough room. So I would like to invite you all and hope to see you all in the near future, not only virtually, but also in person again. Thank you very much.
Thank you. Goodbye.
Bye.
Thank you, everybody.
Thanks, everyone.
Thank you very much.
Bye.
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 Bye.